Good afternoon, everyone. I'm Neil Love from Research to Practice, and welcome to Year in Review. This day we talk about some of the most recent data sets in targeted therapy of non-small cell lung cancer. We have a great faculty today, Dr. Zofia Piotrowska from the Harvard Medical School and Massachusetts General Hospital in Boston, and Dr. Greg Riely from Memorial Sloan Cancer Center in New York. As always, if you have any questions or cases you'd like to run by the faculty, just type them into the chat room. We'll talk about as many of these as we have time. As always, we have a very brief 1-minute quiz for you to take before and after this, and you'll get a lot more out of the meeting if you take that little exercise. We know a lot of people end up listening to our webinars. If you're into audio programs, check out our Oncology Today podcast series, including a recent program with Dr. Piotrowska's colleague at Mass General, Dr. Gaynor. We do webinars all the time, but next week we're heading out to the GI Symposium in San Francisco. We'll be doing 3 live programs out there for those of you in the San Francisco area are going to the meeting, but also we're going to be putting these out simultaneously online. So next Wednesday, a big program on colorectal cancer, on Thursday, upper GI cancer, and then on Friday, hepatobiliary cancer, so check it out. On January 24th, we'll be doing another year in review program on gynecologic oncology, PARP inhibitors, et cetera, et cetera. On the 25th, we'll be doing a program looking at thyroid cancer and neuroendocrine tumors, 2 faculty for that. And then on the 26th, a program with Dr. Rajay on the management of multiple myeloma. But today we're here to talk about a topic we could spend a lot more than an hour talking about, so it's going to be kind of a little bit of a tasting menu. Targeted therapy of non-small cell lung cancer, really non-small cell really took a leadership role in targeted therapy. As we do in all of our year in review programs, I work with both of the faculty today to record a presentation and interview, and we're going to show some of the slides that were presented, but check out that. Those programs are in the chat room, and also we'll be sending out an email with links to the program as well as this program for your colleagues who aren't able to attend today. In these presentations, as always, they go through a ton of papers, piece by piece. We walk through it. Really great to check it out and really get a comprehensive view of what's going on in this exciting field. Again, today we're just going to sort of do a little bit of a sampling of some of the key issues here. And I thought before we sort of dive into the specific mutations, we could take a step back and get into some more general issues about targeted therapy, things that maybe we learned with EGFR and ALK, and now as we get new mutations and new targets, I have a lot of questions. I think a lot of other people do. So Zofia, this is my initial list. I think we can make it a lot longer of some of the issues that come up in targeted therapy. And I'm just going to kind of go back very quickly between the two of you to get your thoughts. So we have 10 or 12, I don't know how many targets at this point that are being either approved or being looked at. And one question is, are you going to do targeted therapy first line? And of course, with EGFR, we had trials originally that compared chemo to EGFR in patients with EGFR mutations, showing that targeted therapy was better. But subsequently, we haven't seen that many. A lot of times we have one-arm studies, Zofia. How do you decide whether or not you're going to use it first line? Is it like a 50 or 60% response rate you're looking for? What are you looking for when you make that decision?
So I think the efficacy certainly has a big part to play in it. I think also, the place where it's approved clearly on a practical level is really important too. I think for many of the targeted therapies that are really effective, you mentioned EGFR, ALK, RET, MET, many of these, we are using them routinely first line. Interestingly, with some of these targets, we actually have data to suggest that the drugs are more effective in the frontline setting than in later lines, like for example, with some of the MET inhibitors. And that certainly plays a role. I think what we've seen is some of the more recent approvals, in particular with the KRAS G12C inhibitors and some of the drugs targeting EGFR exon 20 insertions. The activity is there, but more modest. There are some more toxicity concerns with some of these agents. And I think, with that, the threshold to use them frontline is higher. And therefore, I think we'd like to wait to see some of the first line studies read out before we move those drugs to the frontline setting.
Greg, another clinical paradigm that really started with lung cancer, and now I see this in breast cancer and other tumors, is the idea of doing targeted therapy in patients with brain mets and holding off on radiation therapy, particularly whole brain radiation. Again, when you look at all the different mutations that we're going to talk about today and more, what are the situations? Clearly EGFR and ALK, I think people do that all the time. But as you get into these more recent targets, in what situations do you use that? And in what situations are you more inclined to go with local therapy to the brain, Greg?
Yeah, I think this is really an acknowledgement that some of these drugs are very effective, right? Some of these drugs have very high response rates, and that systemic response rate carries over into a CNS response rate that is really quite excellent. I think it's, there are a number of situations where you're facing this question, and it ranges from that situation where you have one small brain metastasis to the situation where you have 10 small brain metastases. So it's in some ways, it's, when you have a relatively limited number and you're thinking about those sort of focused radiation techniques, stereotactic brain radiation, things like that, it's a harder conversation to have where you're trying to decide if I do radiation and then start the systemic therapy, or do I go with the systemic therapy? But I think the real easy answer is when you have a situation where you'd otherwise be doing whole brain, you can use a targeted therapy oftentimes and move forward. I think, like the decision around first line therapy, you are looking at those sort of raw response rates to decide whether this is a strategy that makes the most sense. And for me, it's sort of a similar bar to what you alluded to earlier, where a 50% response rate, if I have a 50% response rate, I'm going to feel comfortable going straight to a targeted therapy rather than radiation. But of course, there are situations where you might do that even if you have a low response rate, if you're going to monitor the patient closely or they're asymptomatic, a variety of situations.
This has become a big issue in breast cancer with the tucatinib regimen, the Hercline regimen. They're using the lung cancer paradigm. They often will treat and hold off on radiation. So another issue, Zofia, is the use of immune checkpoint inhibitors. Again, we started hearing about this with EGFR and ALK, less effective. A lot of these patients are non-smokers. And so that paradigm kind of has been applied. There are people who don't even use checkpoint inhibitors, not just second line, beyond, for example, in ALK. But what about everything else, Zofia? Some of these, BRAF, you see smokers. In what situations do you completely avoid checkpoint inhibitors? And what situations do you manage these people like they didn't have a targetable mutation?
So I think we have to acknowledge that there's a lot of heterogeneity between these different mutations in lung cancer. And I think we can't necessarily consider all of these different oncogene drivers and mutations in lung cancer in the same way. And I do think you have to look at the activity or the data that we have for the activity of immune checkpoint inhibitors in these different subpopulations when you make these decisions. One of the references that I found helpful in this space was a paper a couple of years ago from the Immunotarget Registry that looked at the efficacy of immune checkpoint inhibitors across different oncogenes. And there we clearly saw that, as you might predict, some of the genes that are seen in patients with heavier smoking histories like KRAS, BRAF, and those had higher response rates to immunotherapy than the oncogenes that were more commonly seen in patients who didn't have a smoking history like EGFR and ALK and others. And I do use that kind of breakdown to help me decide, when and where to use immunotherapy. For example, for a KRAS patient who maybe I'm planning to use a G12C inhibitor in later line therapy, I certainly would feel very comfortable treating that patient with an immune checkpoint inhibitor up front, either alone or in combination with chemotherapy. I think it becomes a little bit harder, to be honest, with some of the patients, for example, with MEDEXON 14 skipping or some of these other less common mutations where we have, really less clinical data to guide us. One thing I will acknowledge is that one of our big concerns with immunotherapy, for example, in patients with EGFR positive disease, is if you give those patients an immune checkpoint inhibitor and then try to introduce a TKI afterwards, we know that there's an increased risk of toxicities, for example, pneumonitis and others with drugs like osimertinib given after immunotherapy. And we have seen that with some of the targeted therapies as well. We've seen that with hepatitis, for example, with some of the ALK inhibitors. We've seen that certainly now with in combinations with sotorasib and immunotherapy as well. So we have to be careful, but I think we also have to acknowledge that we don't have a whole lot of data to guide us with some of the less common oncogenes. And I think we need to try to understand that a little bit better as we make these decisions.
So the last point, Greg, and again, we could talk about all these things for a long time and just trying to increase people's awareness of the issue of adjuvant treatment. We're going to talk about the ADORA trial. But of course, people are asking, what about ALK? What about RET, et cetera? And also the stage 3 unresectable with durvalumab. It took about 2 minutes for that to pop into the chat room. Rubing has a case of a patient with locally advanced disease who's gotten chemo-RT and has been found to have a ROS1 fusion, which actually is the second case I've heard like this. And that brings up, now you're hearing more people talk about targeted therapy with osimertinib rather than durvalumab. Greg, again, how far do you extend the adjuvant paradigm? And what about targeted therapy in the stage 3 unresectable situation?
Yeah, so the adjuvant paradigm it's really fabulous. We've learned a lot over the past few years, and we've learned a lot from rare diseases like gastrointestinal stromal tumor. And we know that, for instance, today that we know ADORA data tells us that giving adjuvant EGFR TKI for 3 years does improve disease-free survival. We'd love to see that overall survival data come forward and give us a little bit more confidence. But it seems like the standard of care today, do you do the same thing with alectinib? Do you do the same thing with lorlatinib? I think these are good questions. I'd love to see data, and this is the sort of conversation we occasionally have with patients. And similarly, in that unresectable disease setting where you've completed chemo-RT and you have a patient with an EGFR mutation, you have a patient with ALK, you have a patient with ROS1, and in those situations where you feel pretty comfortable that the immune checkpoint inhibitor is probably not going to do that much, I certainly have that conversation with patients, and I recommend that we forego the checkpoint inhibitor in that context. And for the case we're talking about here, the patient with ROS1, I probably would hold off on the use of durvalumab in that situation.
And use targeted therapy?
I wouldn't make that next leap. I would hold off on the checkpoint inhibitor because I'm not confident that there's benefit. But to start the targeted therapy at that point would imply that that I have failed in curing them with the chemo-RT, which may come through.
So to be continued. Let's go through some of the specific targets and targetable mutations, beginning with EGFR activating mutations. Zofia, you covered this in your talk and started out kind of talking about the background with the ADORA trial, and went through a couple of papers. One was at ESMO, an update from the ADORA study, and then another paper addressing a practical issue, the use of chemo in patients with EGFR tumors. Where are we today in terms of ADORA follow-up? It looks like the curves still are significantly separate. Any thoughts or comments about this, Zofia?
No, I think overall I'm encouraged to see that the curves, have been maintained, and with longer follow-up, this data is maintained. As we talked about in our session, I think there's some questions about whether those curves will start to come together with longer follow-up as patients complete those 3 years, and whether in the long run, one of the questions we'll have to ask ourselves is whether 3 years of adjuvant osimertinib is enough or whether maybe patients need longer. Again, kind of extrapolating from some of the data from other tumors like gastrointestinal stromal tumors. But so far, I think this looks encouraging, and I certainly do use adjuvant osimertinib in my practice.
So, Greg, I'm kind of curious. Of course, everybody's wondering whether or not the curves are going to come together. And I just wonder if it turns out that they do, and there's no survival benefit, but a very profound disease-free survival. We just did a program on myeloma, I guess it was last night. It seems like 6 months ago. It was last night, talking about transplant having only PFS and no survival. If that turns out to be the case here, you have 1% incidence of brain mets versus 10%. We have to consider tolerability. I'm curious, Greg, what your experience is with osimertinib for 3 years. Do you think globally it would be worth it if it turns out there just is a PSF benefit? Ross Camage talks about this idea of putting a patient in a time capsule and delaying their progression so they can get drugs that haven't been discovered yet. How do you see it, Greg?
I do think that preventing disease recurrence in and of itself is a good thing, right? I think patients would prefer not to have disease. Now, the question is, what is the cost, both the money, but also the tox? And I find the tox is really not such a big issue for the majority of patients. Now, there's always a patient or two that has trouble with these drugs, but I would say that the majority of patients can get through with osimertinib at its full dose without much trouble, and they're content. So I think the cost from a toxicity perspective is really manageable. And I guess, again, I think the disease-free survival is a benefit in and of itself. And let's be honest, I think that with that big of a disease-free survival benefit, I think there's a pretty good chance it translates into an overall survival advantage as well.
I was just thinking about the cost because, you're going to get osimertinib on progression and probably they'll be on it for a long time. Might be interesting. Maybe that has been looked at. What about the use of chemotherapy, Zofia? This has been controversial from the beginning. Docs in practice were, kind of questioning. A lot of them didn't want to use chemo. I think there have been some real-world studies suggesting that. You went through this paper which showed that it doesn't matter whether they get chemo or not, they still are going to get a benefit from osimertinib. Any thoughts, though? People look at the hazard rate with chemo. It's like, 15% improvement. Any thoughts about, offering the patient the opportunity to skip the chemo? Do you do that, Zofia?
So I think it's a really interesting question. I think this paper was practical in helping us to understand that even if patients don't get adjuvant chemo, there's still a benefit to adjuvant osimertinib in this analysis. I think we have to be a little bit careful in taking this data to mean that we can replace the adjuvant chemo with osimertinib. These patients were not randomized to chemo or osimertinib. And the way that I think about it is still in my practice that adjuvant chemotherapy does have a small but real survival benefit for these patients, and I think that has to be considered separately from the decision about the EGFR inhibitor. So if patients are chemotherapy eligible, I still do recommend and try to give them chemotherapy. I agree with you. The benefit is modest, but it is there. However, I think this data gives us some comfort that if you meet a patient who maybe is frail or maybe you don't think is quite as good of a chemotherapy candidate, I think it is very reasonable in that situation to forgo the chemotherapy and give them adjuvant osimertinib. I've also had patients in my practice where we've had the discussion together about the recommendation for chemo, and they've heard the magnitude of benefit, and they've said, you know what, I understand, but thank you. I'm going to skip it. And I think that's reasonable, but I do think that it's an important conversation to have with patients. And I wouldn't use this to kind of forgo chemotherapy across the board.
Greg, any thoughts on this? You could look at it and say, if you give them osimertinib, they have a dramatic reduction in risk of relapse. So is that going to even diminish the benefit of chemotherapy further? Oncology, we're really hearing a lot about patient involvement if they want to be involved. That certainly can be factored in. For practical purposes, how do you deal with this question in the clinic, Greg?
Yeah, I sort of present it that we have two tools that we can use in this context. One is sort of been proven to have a small but real benefit. One has been proven to have a benefit, and we think it's going to translate into something meaningful. But we don't know. For every patient, they can make their own decision on what they feel is most important. And we all know that there are patients out there who want everything, and they want to do everything to improve their odds. There are other people who really start to value the quality of life aspect more. And, I was meeting yesterday with a 76-year-old guy with a resected stage 2B EGFR mutant lung cancer. And, we had this conversation, and he's 76. So getting through cisplatin-based chemotherapy it's a tough one. Maybe it's impossible. And we don't have the data that we'd like for carboplatin-based regimens. And so then we're already sort of stepping down to a data-free zone. And so when you have that conversation and they see the small benefit, they're ready to say, I think I'll just take the TKI. Thanks very much. And I think that's a reasonable decision, probably one I'd make.
So I'm going to go on to the issue of progression on osimertinib. Oncologists and practice are very interested in that and what they need to do in that. But first, real quick, Zofia from Fadi in the chat room, interesting question. What do you think about patients who get osimertinib in the adjuvant setting and then later recur? Can you use osimertinib again? How do you deal with that?
So I think we need more follow-up from ADAURA to know, to have better guidance on that from specifically patients treated with osimertinib. But I think we can extrapolate from older TKI studies that were done with adjuvant erlotinib and gefitinib. And there, first of all, we saw that the rates of relapse while patients were on the TKI were quite low. When these relapses happen, they happen generally after the TKI has been stopped. And we've seen pretty encouraging data so far that particularly the longer patients have been away from the TKI, that's likely that they'll be sensitive to it again. So I think for individual patients, it'll depend on, are they relapsing while they're on the TKI or after? And if so, if it's just a month or two after, you worry about whether the osimertinib will be as effective. But if it's a while after the osimertinib, I think there's a very good chance that these patients will be sensitive. And I think that is data that hopefully the ADAURA investigators will show us over time, the patterns of relapse, the timing of relapse, if any mechanisms of resistance arise, which we hope they won't, but we'll have to see that data.
So let's talk a little bit about the patient who progresses on osimertinib. Zofia reviewed several papers on that. One, looking at the issue of repeat biopsy. A lot of times it'll be liquid, but if you want, if possible, it's great to get tissue so you can rule out transformation. Any thoughts about this study, Zofia? One of the things that was interesting was how difficult it was to get that second biopsy. How do you approach this? It looks like MET is the most common alteration that you see in this situation. You mentioned histologic transformation. Any sort of suggestions about approaching this right now with the available options, Zofia?
So I think that right now still, particularly given the rates of histologic transformations, which look like they may be as high as 15% in some of the studies, and the limitations that we know exist in liquid biopsies, for example, in detecting MET amplification, I think it's still important to offer patients biopsies, tissue biopsies, and get them when we are able. But I acknowledge that there are many situations in which for either, patients are not good candidates for biopsies or the sites of progression can't be accessed. And I think in that situation, certainly worth sending a liquid biopsy, acknowledging the limitations. It is good at finding secondary EGFR mutations like C797S. It may show you MET amplification in others, but the sensitivity for that is less. And again, I think you have to be aware that if a patient has had rapid disease progression and you're worried about a histologic transformation, their tissue is particularly critical.
So now it looks like maybe there are going to be some other solutions to this situation that look encouraging. Greg, patritumab deruxtecan targets HER3, very interesting agent. We saw some data in the EGFR progression on osimertinib setting showed a 39% response rate. Dr. Yanni reported this at ASCO. Can you talk, Greg, a little bit about your vision about first of all, what HER3 is, what this antibody drug conjugate is, what side effects you see, and whether you think this is going to be something that's going to come into practice in this situation of progression on osimertinib?
Yeah, so this is, I think to my mind, an exciting new area. We're seeing these antibody drug conjugates getting developed kind of across oncology. We've known about the concept, and there were drugs approved 20 years ago using this concept, but they really are, there's a whole crop of them coming up now that are pretty exciting. Now, this one targets HER3. We all know about HER2. We'll talk a little bit more about that later. HER1, people sometimes forget that's EGFR. So EGFR is, as a mechanism of resistance, we oftentimes see overexpression of HER3. And so then that serves as a beacon for this drug to target the HER3 on cancer cells that have become resistant to osimertinib. And, as you see the data presented here, it's pretty impressive in terms of its response rate. It shows us that this is a viable path forward. I think there are more things to learn about how it works and how well it works. One thing that's important to learn is should we combine it with osimertinib, or should we combine it with an EGFR TKI, or is it going to be enough on its own? These are things that we're going to learn, but I would anticipate this moving forward to an approval as a single agent over the coming year or so. But it definitely looks exciting. as an antibody drug conjugate, the side effects you see are chemo side effects, right? So this is things like thrombocytopenia, neutropenia, fatigue. It's that chemo component that you're seeing the toxicity from. But again, as you see here, this is a pretty modest toxicity profile for a new agent in this space. There are rare instances of significant toxicity, but most patients get through it pretty doggone well.
So, Zofia, when you see the last name of deruxtecan, of course, one of the things you think about is ILD, and I see down there in the lower right they saw some ILD. Again, any thoughts? You sort of summarized in your talk what your view is. Anything you want to say? One of the things you bring up is the issue of biomarkers. I assume HER3 is not very predictive, or you can tell me. But any other comments?
No, I'm also excited about this drug and this class of drugs, ADCs in general. I think what's most encouraging here is, as we look at these different resistance mechanisms after osimertinib, none of them are kind of the predominant resistance mechanism like we saw with T790M after first and second generation EGFR inhibitors. So I think these types of drugs that have activity across different resistance mechanisms are on a practical level just going to be a lot more useful as a tool for us in the clinic. And you can imagine that patients, even potentially without a biopsy, may benefit from this. And that would, of course, be great. I think in terms of a biomarker specifically for a response to this agent, you're right. The limited data that we've seen so far seems to suggest that just HER3 expression is not the right biomarker here. And I hope that maybe in the future we will have one because, 39% response rate is good, but it could be even better, I think, if we could select the right patient population. But I am really excited about this agent. I think both as monotherapy and as Greg alluded to, potentially in combination with osimertinib. So I think we have to stay tuned to see what we see over the coming years.
The other strategy, Greg, that Zofia talked about that I thought was very exciting is the idea of using the bispecific amivantamab, which we're going to talk about in a second, with the MET bispecific with lazertinib, which to me looks a lot like osimertinib, so it makes a lot of sense. But one question I was going to ask before, when patients do progress on osimertinib, Greg, and for example, if they're going to go to chemo, do you keep the osimertinib going? For example, a patient who had brain mets? And then what are your thoughts about this strategy of amivantamab, lazertinib? Would you like to be able to use it right now, Greg?
Yeah. So with the initial question of, patient progressing on osimertinib and you're going to start up the platinum doublet chemotherapy, do you maintain the osimertinib? And I'd say that my general approach is that I do, though I'm not wedded to it. And so, when a patient tells me about increased toxicity or there's any sort of reason to stop, then I quickly do stop the osimertinib. You do hear a lot of folks talk about the idea that it's particularly good in terms of suppressing brain metastases to continue osimertinib. I haven't been so convinced that that's the case, but I think it's one more reason to do that. Moving on to the amivantamab lazertinib combination, I think this is certainly an exciting combination. I think that this is where amivantamab, I think they wanted to move here in treating EGFR resistance as sort of the big target for them. They got the initial approval for patients with EGFR exon 20 insertions. So that's where we all think of it today. But this combination of a TKI plus a bispecific antibody that targets MET really seems to hit all the right marks in terms of options for TKI resistance.
So we also want to talk about, and Zofia reviewed in her talk, exon 20, EGFR exon 20 insertion mutations. You reviewed a bunch of papers, and of course, a lot of the focus is on the TKI mobocertinib, and again, the bispecific amivantamab. Can you kind of summarize your bottom line, Zofia, about these two agents, how you decide which one comes first, and where you see things heading in this field?
Yeah, so it's nice, I think, to have two approved agents for patients with exon 20 insertion positive non-small cell lung cancer, both in the second or later line setting. So both post chemotherapy approvals. So this is one of those targets where actually I don't use these drugs first line outside of a clinical trial. I treat these patients with chemotherapy first line, talk about chemoimmunotherapy, as an option as well. And then we're really picking between these two. So they have different mechanisms of action. Mobocertinib is an oral EGFR inhibitor. amivantamab, as we just talked about, is the bispecific antibody against EGFR and MET. It's intravenous. It's given initially weekly for the first 4 weeks and then every other week. Both have activity, although I would say the activity with both of these agents is modest. The response rates with both of these agents are in the 30 to 40% range. So they really do fall short of what we're used to seeing in terms of response rates, for example, with osimertinib for the classic EGFR mutations. The progression-free survival, again, is modest with these agents, about 7, 8, 9 months in that range. And I think in addition to different routes of administration, oral versus intravenous, the safety profiles of these are also different. So with mobocertinib, what we see most are some of the GI toxicities related to inhibition of wild-type EGFR. We see diarrhea in 90% of these patients, grade 3 or higher diarrhea in 20%. We can also see some dermatologic toxicities. So even though there's some appeal to an oral agent, I think we do have to monitor these patients very closely, in particular for those GI toxicities. Conversely, with amivantamab, it's an infusional therapy, so that's a little bit less convenient for patients. The biggest side effects are the infusion reactions, which can sometimes occur on cycle 1, day 1, and generally are low grade and manageable. And even patients who have these infusion reactions are able to then go on to be treated successfully afterwards. But it is something you have to counsel patients and watch out for. And then dermatologic toxicity. So rash is seen in about 80 to 90% of these patients, although largely low grade. We can also see some paronychia and other skin toxicities. So I think, when you have a patient who's progressed on chemotherapy, who has these two options in front of them, I discuss both options really with the patient and go through this and kind of talk about the pros and cons of each and try to make decisions that are in line with what the patient's goals are and practical considerations. If the patient really leaves it up to me, I have to say I will often lean towards maybe amivantamab first, just because I think the response rate looking across clinical trials is a little bit higher if patients are willing to come in. But I think both are very reasonable options. And many patients will say, I'd like to try the oral option first.
Greg, anything you want to add to that? What's your usual first targeted therapy in this situation?
Yeah, I'm pretty similar to Zofia. We talk a lot about it, and I think it's nice to have the ability to go kind of back and forth, right? You can whichever one you start with, you're going to do the other one next, and that's the way I pitch it to patients. Is that we're gonna do both of these. Which one do you want to do first, and which one do you want to do second?
So we're going to talk a little bit about ALK and ROS1, and you covered that in your talk. Again, hopefully people will go to the talk and go through all the details. I see in the chat room, Venue has a patient started on first-line lorlatinib who now relapsed at 1.5 years, wants to know how to approach that. I actually asked her in the chat room. I was curious how the patient did on the lorlatinib, incidentally, Greg, and she said she did well, no CNS side effects, but had some lower extremity edema. So again, Zofia went through a whole bunch of papers, but of course, of great interest is lorlatinib and the CROWN study. She updated a couple of the other papers with alectinib and brigatinib. But Greg, what's your take right now on optimal first-line therapy for ALK? Your thoughts about lorlatinib? And any thoughts about what to do with people who progress in terms of second line? Do you look for mutations, et cetera?
Yeah. So I think first line therapy, it's really kind of amazing. We have a small group of patients, 4 or 5% of non-small cell lung cancer have ALK positive disease, but we have a range of options in front of us. But I would say it ultimately boils down to probably 3 agents that most docs are choosing from at that point. You've got alectinib, brigatinib, or lorlatinib. Now, all these have been compared to the old drug crizotinib in frontline randomized trials. So when you look at sort of cross-trial comparisons with the common control, you see that lorlatinib kind of stands out as the drug with the best hazard ratio and the most suggestion of benefit in the first line setting. So I think, from a raw data perspective, lorlatinib is the way to go. The thing that kind of slows us down from making that the hands down choice is really 2 things. One is the toxicity component. There's a little bit more tox with lorlatinib, in particular the CNS side effects, some neuropathy type side effects. But I think as oncologists, we're used to managing those. Probably the other big thing that slows us down, though, is this notion that, you want to have something available when the patient progresses. And so if you give them alectinib or brigatinib and they progress, then then, you feel more comfortable having lorlatinib available. That said, the response rate for lorlatinib in that second line setting is not dramatically better than what we see with platinum doublet chemotherapy. And so it's not the best option to have. So, I've given you sort of a pro and con of all sorts of options. What do I really do? I usually end up giving alectinib as my first line therapy for most patients with ALK-positive disease.
So, and Zofia, you told me that you're kind of leaning more towards lorlatinib, and I was telling you that this Friday we're recording. It's not going to be live. We're going to put it out as an enduring program. We're doing a 2.5 hour long think tank on ALK. So look forward to some extensive discussion. Any quick advice to Venue about what to do when this patient has progressed after a year and a half on lorlatinib, Zofia?
No, I think that there's some interest in sending, for example, a liquid biopsy to look for ALK resistance mutations. But at the end of the day, I think outside of a clinical trial, most likely my next go-to would be platinum doublet chemotherapy for someone like this. Or, there are novel ALK inhibitors in clinical trials. So if the patient's near an academic center, that would be another thing to consider.
So here are a couple papers that Zofia reviewed on ROS1, Greg, and, the issue of entrectinib versus crizotinib and the question of, maybe a better, or not maybe, but better CNS activity, entrectinib. How are you approaching this, Greg, particularly in a patient who doesn't have brain mets?
Yeah, I think in a patient who doesn't have brain metastases, I'll be honest, I typically will use crizotinib as my first line agent. And that's really, again, a toxicity question. We don't have any suggestion that entrectinib is superior to crizotinib overall for patients with ROS1 positive disease. There is some hint of better CNS activity, but the median progression-free survivals in studies look very, very similar. And so from a toxicity perspective, so I then make my decision based on toxicity, and I generally feel like crizotinib is better tolerated.
So it's killing me not to present all these cases in the chat room, but we're going to get to them at some point. We may not do it today, but we will get answers to these. But everybody has questions about targeted therapy, and here we go. Now we're going to get into even more interesting stuff, HER2 and particularly TDXD. And Zofia, of course, we talk about this all the time, not only in breast cancer, but GI cancer, particularly upper GI, where next week we have Greg's colleague, Dr. Jan Gijan, will be talking about TDXD and upper GI cancer. Can you just sort of provide a little bit of a capsule? We can spend the whole hour just on this, Zofia, but particularly the issue of mutant HER2 as opposed to amplified. Of course, in breast cancer, we're focused more on amplified disease, and they rarely see mutations. But this is a pretty good looking waterfall plot in the HER2 mutant situation from this New England Journal paper. Any comments, Zofia?
I think that, to summarize very briefly, quite a lot of work that's gone into this is, I think that there are HER2 mutations in non-small cell lung cancer seem to be the real potent driver here, and the target that leads to the highest efficacy rates. That can sometimes overlap with HER2 amplification, but not always. And then, of course, you can have, in some cases, HER2 amplification in the absence of a HER2 mutation. But I think when we identify patients with HER2 mutations, which is seen in about 2% of all non-small cell lung cancer, and I think is enriched in patients with a limited smoking history and some of the other factors that we're used to seeing with other oncogene drivers, that really is the population that I think derives the most benefit from this drug and where we see the most impressive response rates. I think you might show some of this data, Neil, that TDXD does also have some activity in patients with HER2 overexpression or amplification, but it is more modest. And I think the challenge is that's not something we necessarily routinely look for in our lung cancer patients, whereas, and whether or not we should, I think, is an open question. But most important, I think, is to make sure that when we're testing patients, with next generation sequencing panels, that we're now including HER2 and we're looking for those HER2 mutant patients because they really do seem to benefit from TDXD. And I think it can be an effective treatment strategy for them.
So, Greg, another issue is the dose of TDXD, and Zofia went through a paper that compared a higher dose to the standard dose, and I think all they saw was more toxicity. But I wanted to bring up the question because at San Antonio, we did a symposium, we did actually a couple of them, where we had docs in practice presenting cases, and Dr. Astral, who's your neighbor there in Brooklyn, presented 2 cases of people in their 90s that he actually started out on a low dose of TDXD, and one of them escalated. They both had great response. They both had an uncomfortable, painful chest wall disease that went away. Can you talk a little bit about, and here are the different doses, and I guess in upper GI, there's a higher dose that's approved, but also the dose reduction. Greg, any comments? I guess this study looked at higher dose and all they saw was a little more toxicity, maybe not any greater benefits, so they stuck with the current dose. Any thoughts about that? And also particularly the issue of starting out at a lower dose that was done in these 2 breast cancer cases. Do you ever do that, Greg?
Yeah, so it's interesting. We've always in oncology gone to the highest dose. That's what we were taught to do, and that's what we do. So that's how drugs are developed. But with antibody drug conjugates, I don't know that that's the right paradigm. I mean, we ultimately are using chemo. That's the warhead here, if you will, and so or the payload here. And so we do have to get a dose that we believe is efficacious. But what that is and what's right for the patient in front of us, I think is an open question. And I think that's sort of the art of oncology, and we do that every day when we dose reduce first line chemotherapy for that patient in front of us who's maybe performance status is borderline or a little bit older. I am thrilled though that while we've seen lots of data over the years saying that you got to use the highest dose, we're actually seeing and this is probably largely FDA mandated, we're seeing a lot of dose exploration and in a way that we hadn't seen before. And so this trial that you're seeing in front of you is an example of that. And that's, they looked at 2 different doses. They looked at the response rates. They looked at the toxicity. And you see here that with the higher dose, you get higher toxicity, but you didn't see a difference in response rate, or you saw a difference in response rate, but the lower dose was better. And that may have just been because they were able to give more doses.
Zofia, any comments about this, and also where you see this fitting in? I hear a lot of people talking about using TDXD first line in people with HER2 mutations. What are your thoughts, Zofia?
I think in terms of the dose, I agree. I mean, I think that the data is pretty convincing that there is no need to push the dose higher than a 5.4 for lung cancer patients. I think, it's nice to see the lower rates of ILD, because I think that was one of the concerns with this drug in the lung cancer population. In terms of, first line use, we started this program by talking about kind of percentage response rates that would push you to use a drug first line. And we said that threshold was in that 50 to 60% range. And I have to say, TDXD does make that mark. And I think it is an active drug. So I think it's certainly worth having a discussion. This is something we discussed in our tumor boards, but I would feel comfortable, using this drug in the frontline setting based on the data that we have so far. I think it's also reasonable to give patients chemotherapy first and use the second line. But I think that this efficacy signal is compelling enough to support frontline use.
Greg, your macro view, and a lot of people have that, this is kind of a variation of delivering chemotherapy, also relates to the issue of chemotherapy side effects. We first started to hear this from the breast cancer people, GI side effects, alopecia. But in terms of GI, do you go ahead and use preemptive GI medications as in the package insert? And what do you end up seeing in terms of chemo-like toxicity with TDXD, Greg?
Yeah, I definitely use prophylactic antiemetics. I use dexamethasone. I use palonosetron as a preemptive strike against nausea in this context. So I think that's critical. Other chemo side effects you see are the myelosuppression. We do see a little bit of that. And I think that the one that you occasionally do see is alopecia, which is always a surprise to us when it does occur, but one that I always mention to patients so that they're on the lookout for it.
Zofia, final comment about TDXD and the issue of ILD, which of course is a big concern. We talk about that all the time in breast cancer. How do you look for it? Finding symptoms. Do you use imaging? But now you have a disease that occurs with people who have you often have issues in their lungs, either the cancer or comorbidities from smoking. How do you see this playing out, Zofia, in your practice? And do you use imaging as a way to look for ILD to get it before it becomes symptomatic? And what do you do if somebody starts out symptomatic from COPD?
These are really important questions. And I think that the one advantage we have in the lung cancer space is that so many of the drugs that we use these days can cause ILD. So I think it is something that many of us are quite comfortable, counseling patients about and looking for. I think that the tools that are most helpful to look for ILD really are just careful symptom kind of, monitoring for symptoms. And so all of my patients who I start on TDXD as well as immunotherapy and some of the TKIs, I counsel them that this is a risk and that if they have increased shortness of breath, increased cough, anything else like that, even mild changes in dyspnea and exertion, those are things that, warrant a phone call to us right away. And the best way to diagnose this is by CT imaging, of course, to look for those, kind of classic ground glass opacities and findings that the radiologist can usually tell us are most consistent with ILD. Sometimes it comes up that we notice changes on routine restaging scans. And this is a scenario I've been in quite a few times now in the clinic. You get a scan just to assess treatment response and the radiologist calls you and says, I see new changes, new ground glass opacities. I'm concerned this patient may have pneumonitis. And you go back to the patient and the patient is completely asymptomatic. Those are cases, that are challenging because I think that's mild grade 1 pneumonitis, but it is something that can blossom into, more significant pneumonitis. And so in those cases, I will often hold treatment and obtain a short interval follow-up scan. I'll have those patients monitor closely. Whether or not to use steroids or kind of treat ILD is really for me guided by the presence or absence of symptoms. But I do think that even radiographic only ILD needs close monitoring and careful management.
So Dr. Kumar in the chat room has a patient who continues to smoke and refuses to quit and wants to know is that you consider that a contraindication to TDXD? I'll just let you think about that without diverting out into that because I want to hear about NRG fusions. Here's a new one for you to check out. Zofia, can you talk a little bit about, first of all, what an NRG fusion is and why we're using an anti-HER3 antibody, seribantumab, as you can see, has even though a small number of patients, pretty nice looking waterfall plot. So what are NRG fusions, Zofia, and why are we using seribantumab?
So this is, I think, one of the newer targets, when we talk about kind of upcoming targets and genes where we may find that we have an improved targeted therapy in the future, I think NRG is kind of at the top of the list for the next generation of targets to look for in lung cancer. And I think it really is important to look for these in our patients and to ensure that you're using molecular testing that covers these. NRG signals through the HER family. It actually, signals through the HER3, which we also talked about earlier with patritumab deruxtecan. And so while this is an NRG fusion, they're actually an anti-HER3 antibody, seribantumab, has shown some activity in this small study that you can see on the screen here with a response rate of about 33% in this small number of patients. These are early days. This is still in clinical trials. This is not yet an approved agent for these patients. But what I think it tells us is that NRG fusions, which are uncommon, but when you find them, are potentially targetable. And so it is important to identify these patients and again, I think if possible, try to treat these patients, to enroll these patients onto clinical trials or refer them for clinical trials. There is some limited data out there using pan-HER inhibitors like afatinib and others for NRG fusions. I think that data is very, very limited at this point. So I think clinical trials are really the preferred way to treat these patients right now.
So Greg Foddy in the chat room wants to know, what about patritumab? That's a great question. And NRG fusions, has that been looked at? And any thoughts also, Greg, about, we talked about, sort of a macro view of targeted therapy, a nice looking waterfall plot. Like how much data do you need before you start using a drug in this situation? You're clearly not going to be doing a randomized study. So any comments about patritumab and also how much data you need to want to use a drug like this?
Yeah. So for patritumab, I think most of us in this space have started wondering that exact same question. What about patritumab? And is this going to be a useful thing in this context? So we haven't seen any data yet, but all of us think it's a good idea. So I think you're right on. Now, how much data do we need for seribantumab to start using it? Of course, the real answer is we need enough for the FDA to let us use it because it's not an approved agent yet. But But to get to that approval, what's it going to take? I think it's going to be a single arm study. The rarity of this agent is similar to what we see with NTRK or RET, and those drugs got approval based on single arm studies of relatively small numbers of patients, and I'd expect the same here.
Yeah, we had a big discussion last night because there were 2 drugs in melanoma that were pulled off the market that were initially approved based on phase 1 studies, didn't pan out in the randomized studies that they chose to do. And people are like, I have this patient's been on it for 2 years, and, why is this drug not being approved? Well, anyhow, that's a whole other issue to consider. But let's get back to the nitty gritty here. RET, common issues that come up. Certainly docs in practice see that. Zofia, you reviewed selpercatinib and pralsetinib. Can you just sort of provide an overview of what we know about these agents, what we know about RET, and in general, how you're approaching these patients, Zofia?
Yeah, so RET fusions are another, kind of small piece of that pie of molecular drivers in non-small cell lung cancer. About 2 to 3% of patients are RET fusion positive. And we have 2 approved agents now for these patients. Both pralsetinib and selpercatinib are approved, and both have shown really, excellent activity, I would say, in the studies that were updated this year with both of these agents. I think the key factors here are they both lead to high systemic response rates in the, 70% range, as you can see in the frontline setting here with pralsetinib, similar outcomes with selpercatinib. With these drugs, I think, like I may have mentioned earlier, we are starting to see some hints that they have even better efficacy when used in the frontline setting than in later line settings, although they're certainly effective in both contexts. Both have CNS activity. So for patients with brain metastases, I think these are very reasonable options to consider for patients who are diagnosed and have small asymptomatic brain metastases. These would fall into the category of patients where I would, consider starting a RET inhibitor as soon as possible, and just monitoring their CNS closely. I think the question that comes up most really is almost an abundance of riches. We have these 2 very active drugs, and how do you choose between them? And I think that the data for them, their safety profiles are really quite comparable and very, very good. And I think both are reasonable options.
Greg, any thoughts about how you approach these patients? Also, I love this approach here, looking at patient-reported outcomes. Again, we were talking about this last night with myeloma, that, it's one thing to see a response rate or duration of response, those kind of numbers, but it means a lot, too, when you see that the patients feel better, and to actually even look at that or make an attempt to demonstrate, if you have a one-arm study, that the patient's quality of life is improved. Any thoughts about that, Greg? And also trying to document that. A lot of times I read, quality of life papers, and I sort of kind of can't identify with it. I talk to you all, and it kind of gives me a better idea. Do you agree that these drugs from a quality of life point of view are sort of interchangeable, Greg? And how do you make the decision?
Yeah, I think both these drugs really work well to make patients feel better. And I think we've had quality of life instruments for probably 30, 40 years that have been explored in oncology. But the truth is that I think our drugs were tough. Right. And so the quality of life of having cancer compared to the quality of life on some miserable drugs, it kind of was a wash. And so it made it really hard to interpret these data. But I think when you have very selective agents with a good target, you can really see dramatic quality of life benefits. And we've improved the quality of life instruments a lot. We have, instead of patients drawing a line on a scale, sort of guessing how they feel one day, now we have, a variety of app-based approaches to collecting this data. And we also have more specific data with patient-reported outcomes where patients are grading, their nausea, grading their bowel movements, and it's a very rich set of data that has been built by a lot of people, including Ethan Bash, Deb Schrag. They've put together these platforms that allow this study, and I think that stuff's going to move us forward.
Yeah, I love the idea of the apps, and, maybe even getting data from patients on a daily basis, very briefly getting them, you have it just like, how do you feel today? Like, well, do you have any symptoms? We were talking last night, they used to have a thing called TWIST, time without symptoms. They tried to compare. So again, as you said, Greg, this has been a long-standing challenge in oncology. So what about MET exon 14? Again, we have 2 agents, tepotinib. Again, seems to be very effective, well tolerated. But also we're seeing amivantamab looked in this situation. Can you provide and also capmatinib as well? Again, can you kind of provide a little bit of an overview, Zofia, how you think through exon 14, first line versus second line, IOs, and particularly choice of targeted treatment?
So for patients with MET exon 14 skipping, I think the MET inhibitors, the selective MET inhibitors like capmatinib and tepotinib clearly are very effective for these patients and are my preferred first-line agent. So I generally reach for the targeted therapy first for a patient with MET exon 14 skipping. Again, like with some of the other targets we've talked about tonight, I think that looking across these trials, the data with capmatinib and tepotinib are both very good and in my mind, I think quite similar. So I don't think one clearly stands out as my preferred agent over another. We have maybe a little bit more CNS data with capmatinib, although there is now emerging data with CNS activity of tepotinib as well. With MET, again, I think we see this trend where this targeted therapy is a little bit more active in the first line setting and then in the later line setting, and that's one of the reasons that push me to reach for the targeted therapy first. I think the question of the efficacy of amivantamab in patients with MET exon 14 skipping is a really important and interesting one. This is a bispecific antibody that targets EGFR and MET, and so certainly I think that we're and are very hopeful that this may be an active drug. We do see, the numbers in this study were small, but we do see some activity here. What I would say I was disappointed to see in this study was that the activity after a prior MET inhibitor was actually, the most limited. Small numbers of patients, but the response rate there was only about 17%. And I think that is a place where I would have the most hope to use this agent. We know that capmatinib and tepotinib are very active for these patients, but they, eventually resistance develops. And so I would have been very hopeful that maybe amivantamab would be an option afterwards. And it seems from this little bit of data that we're seeing so far that the activity there is modest at best. And so, we'll have to see going forward where there's any combination studies that might be done or, how best to use amivantamab in these patients. But I think it's an area that we need more study. I think there is some toxicity with all of these agents. In particular, the edema is something that we have to watch for, the cumulative toxicity. We see this certainly with the MET inhibitors like capmatinib or tepotinib, but interestingly, even with amivantamab, we do see edema in about 15% of patients. So that seems to be a class effect related to MET inhibition.
So final topic, KRAS G12C. Greg, you reviewed that in your talk. Can you talk a little bit about what we know about the now two agents, sotorasib and adagrasib?
Yes, we have two FDA-approved agents for KRAS G12C today, and we find KRAS G12C in about 12 or 13% of patients with non-small cell lung cancer, so it's an important target. Sotorasib got an accelerated approval about a year ago, and adagrasib got its accelerated approval recently. So we recently, at one of the big meetings this fall, we saw this data where they compared sotorasib to docetaxel, kind of a standard second-line agent in this context. I think it was no surprise to most folks that we saw an improved response rate for sotorasib compared to docetaxel. We saw an improved progression-free survival with sotorasib compared to docetaxel, but we didn't see a benefit in overall survival, which was, I think, disappointing. But where I think sotorasib is clearly better than docetaxel is toxicity. This is the plot here of toxicity, and you see that for patients who got docetaxel, the only place where it didn't look so good was maybe in diarrhea, where sotorasib had a little bit higher rate of diarrhea. But in virtually every chemo-related side effect, docetaxel was much worse than sotorasib. And so as a consequence of that, I think it's pretty clear that using a KRAS G12C inhibitor is the right second-line approach because of the improved toxicity and fairly comparable, if not improved, efficacy in that setting. So we've seen the data for sotorasib. We've also seen data for a newer agent called adagrasib. And this is the New England Journal of Medicine waterfall plot here showing response rate that might be slightly superior to sotorasib, but hard to compare directly. One thing that they've done with adagrasib is made an attempt at looking at CNS efficacy. This is some retrospective data that has some flaws, but it does suggest CNS efficacy for adagrasib. And there's also prospective data out there looking at adagrasib in patients who've had no prior therapy for CNS metastases and shown efficacy as well. So I think both adagrasib and sotorasib are KRAS G12C inhibitors that we can use in clinic today. And it's really wonderful to have agents in this space. And we look forward to the next generations of drugs that target KRAS G12C and other genotypes of KRAS as well.
Zofia, any thoughts? And also for practical purposes, even though we need more data, you got to make decisions today. An oncologist got a patient in their clinic right now. Any way to decide which one of these agents are going to use? No reason to think sotorasib won't work in the brain, but maybe we don't have as much data. If you have somebody with brain mets, would you be more likely to use adagrasib, or is this just a coin flip, Zofia?
I think, the CNS is probably the one place where, from the data that we have, I think we can say, we have a little bit more, albeit flawed and limited data for adagrasib. So I think if I have a patient with CNS metastases, I might be inclined to reach for adagrasib over sotorasib, while we await more data. Other than that, I think these drugs really are very similar. Sotorasib is dosed daily. Adagrasib is dosed BID, but sotorasib, you have to take 8 pills once a day. And with sotorasib, I think it's about 3 pills twice a day. So, I think that there are some slight differences there. But overall, outside of the issue of brain mets, I think that that really both are very reasonable agents. And I would not feel strongly about one versus the other.
So, Greg and Zofia, thank you so much for working with us today. Again, we could have spent a lot more time. It's just a little bit of a tasting menu. Audience, thank you for attending. Come on back next week. It's GI cancer time, colon, upper GI, hepatocellular, biliary tract, so much going on. Really looking forward to seeing what our faculty has to say. Be safe, stay well, and have a great night. Thanks so much, Zofia. Thanks, Greg.
Thank you.
Pleasure.